Hello, everybody. Welcome to our webinar today on the Bipolar Disorder Survival Guide, the third edition, with David Mikulec, PhD. David Mikulec is a professor of psychiatry at the University of California, Los Angeles, Seminole Institute, UCLA School of Medicine, and senior clinical researcher in the Department of Psychiatry at the University of Oxford, United Kingdom. He directs the Child and Adolescent Mood Disorders Program at UCLA, where he supervises psychiatry and psychology trainees and conducts research on psychosocial interventions for children and adolescents with bipolar disorders. Dr. Mikulec's numerous publications include the best-selling self-help resource, The Bipolar Disorder Survival Guide, 3rd edition, as well as acclaimed books for professionals including Bipolar Disorder, 2nd edition, A Family-Focused Treatment Approach, and with Michael J. Gitlin, Clinician's Guide to Bipolar Disorder. He has received Distinguished Investigator Awards from the Brain and Behavior Research Foundation, the Depression and Bipolar Support Alliance, the International Society for Bipolar Disorders, and the Society for Science of Clinical Psychology. Thank you so much for joining us today.
Thanks, Aubrey. Hello, everybody, and welcome from not-so-sunny California. So it's been raining all week long. I'm sure you feel terrible for us. Anyway, I am going to talk to you a little bit about tips for families on coping with bipolar disorder. So what I'm going to be talking about is relevant to a person with bipolar disorder, as well as parents or spouse or siblings, as broad an audience as possible. Some of what I'll be talking about are kids and adolescents with bipolar disorder, and some of it will be really more about adults. And plenty of time at the end to answer questions. Let's just forge ahead. This is the book. This is the shameless part of self-advertising in this talk. This just came out with Guilford Press. What I'm going to be talking about is covered in more detail in the book. I hope you find it useful. Make sure you get the 3rd edition. There are 2 other editions out there. The blue one is the right one. So first, we're going to talk about the symptoms of bipolar disorder and how they affect the family. I'll talk about our treatment here at UCLA, FFT as we call it, family-focused therapy, as well as other new treatments, both medical and psychological, that are on the horizon. Talk about illness management strategies, dealing with medication non-adherence, marijuana use, particularly in bipolar teens, and what do we know about it. Talk a little bit about diagnosis and the overlap, particularly with borderline personality and ADHD, both of which are frequently confused with bipolar disorder. And I'm going to end on a somewhat more positive note by talking about what we know about bipolar disorder and creativity. We do know that there is some good evidence that creativity and bipolar disorder go together and are sometimes inherited in the same families. So first, when we talk about inheriting bipolar disorder, we're not necessarily saying everybody has a bipolar parent. More often what happens is we have a family tree that looks like this. So Nancy is the one with bipolar disorder in this 3rd generation. She has a sibling who's healthy and a younger sibling with a possible substance abuse disorder. Her mom was depressed, but not bipolar. Mom's brother may have had bipolar disorder. We know that he had alcoholism, but we don't know for sure whether it was in the context of severe mood swings. Dad doesn't seem to have any psychiatric illnesses on his side, although there are physical illnesses, of course. Mom's mother died at 78. We think she had depression. Mother's father is still healthy. So this is just by way of illustrating you won't necessarily find a bipolar person in your 1st or 2nd degree relatives. It may be something more on the bipolar spectrum, like bipolar 2 or alcoholism with mood disorder or major depressive disorder, all of which are genetically related to bipolar disorder. I'm more interested in the effects of bipolar disorder on the individual and the family from a psychological point of view. We know that when people have bipolar disorder, their behavior strongly affects their family members. And that's much of what the Bipolar Survival Guide is about. If it's a teen or an adult, they can often become aggressive and hostile. We know that teens and adults self-isolate during depression, and their families get concerned about suicide. We also know that it works the other way around, that intensive family conflict and conflicts that don't get resolved and lots of criticism can contribute to earlier and more recurrences in the person. Sometimes they're driving that conflict, sometimes other members of the family are driving it, but we do know that family conflict is a risk factor. Parents often become exhausted when they're taking care of someone with bipolar disorder, suffer from physical illnesses as well as their own depression and anxiety. It's very hard to be, say, a parent of a 15 or 16-year-old who's showing these very severe mood swings, or an even younger child who's being thrown out of school because of aggression and so on. I will say more about that later. Often forgotten are the siblings who feel unimportant. All my parents' attention is on my brother who has bipolar disorder. He's got something wrong with his brain, so now they don't care about me. Sometimes you see them developing depression, or they act out or externalize in some way, just as a way of settling the score and getting attention. All of this can lead to stigma. The family feels isolated. They're afraid to tell people outside the family about the disorder and the child for fear that the child won't be invited over anymore, or if it's an adult, they feel that there's a sense of shame that many families feel brought on by the misunderstandings often of the society about what bipolar disorder is and isn't. It's changing, but it's changing very slowly. So this is all to say that it's very difficult for a family to cope with bipolar disorder, and it's also very hard for the individual. One time, a more humorous note, a mother once gave me this picture and said, "You've been asking me what it's like to be the parent of a 16-year-old. And that's me on that string. My son is like a big baby puppeteer, keeping us all on a string with his vicious mood swings. First of all, he seems delighted that he can do it." When you do hear this, that parents often feel disempowered, that the kid is kind of ruling the roost. Siblings are angry that the kid gets away with so much, maybe 16 years old, crawling out windows at night, spending the night elsewhere, and the parents are really at a loss as to how to set limits. You get the sense that this is contributing to the child's grandiosity. So that's a real puzzle. Let's talk about family-focused treatment, or FFT. This is one of the modern evidence-based treatments that we've tested in numerous randomized trials. It's given in conjunction with medications, usually right after an episode. So we wait for an episode of depression, hypomania, or mania to occur. And when the person is starting to resolve or starting to recover from that episode is often when we start family-focused therapy. We keep them, if they want medications, we keep them on medications during the treatment. It's 12 sessions over 4 months, and it involves the person with the disorder and anyone who lives with them. That can be parents, siblings, grandparents, or in adults, it can be a spouse, still be parents if it's an adult, or older siblings sometimes. The first component of treatment is psychoeducation. It's a term you're probably all familiar with. It means more than just education. Education is what you can learn just on a website about bipolar disorder and how to manage it. Psychoeducation is a more personalized process where we try to learn what symptoms the person has had and what the family recognized to be the beginning of the episodes, the most recent manic or the most recent depressive episode. How did it start? How did we know it was developing into a full mania or depression? What were the first signs? And sometimes family members are very good at this. They'll say, I know when he's getting manic because he just gets this look in his eyes, or he starts watching more TV to see if his name is going to be called. Where she starts hiding food under her bed, or she's up late at night doing all sorts of Instagram posts. These things are often warning signs. So we try to hammer out, how did the most recent episode develop? Over what time? What were the symptoms? What helped? What didn't help? If there was a hospitalization involved, how did that come about? And try to develop the sort of deliverable from this part of treatment is what we call the relapse prevention plan, which is an individualized plan for the family. What are the symptoms of what are the early signs of a recurrence? What can the family do if those signs occur? Who can they call? And I should say it this way, also stressors. What are the stressors that trigger those episodes? What are the symptoms or early warning signs of those episodes? And what should the family do when they recognize those? Should they call the doctor? Should they arrange a medication evaluation? Should they try to organize sleep-wake cycles more effectively? Does the person need some time off work? The various things that can be done to try to minimize the effects of these episodes beyond just simply taking more medications. That's what we try to put into the prevention plan. Later on, we work more effectively with the family's communication styles. Often they've really lost touch with each other in the midst of these episodes. People feel like they're being taken for granted, or their efforts to be nice are not being recognized. Often the patient will say, I feel like you're criticizing me, even when you don't say it. You're criticizing me with your eyes or your tone of voice. It keeps them effective speaking and listening strategy, sitting down, talking to each other, learning, say, for example, how to paraphrase what each other has said, how to give positive feedback, compliment the person once in a while, how to ask changes in the family or changes in the family environment. And all this leads up to problem-solving skills, which is training families to identify specific problems in the household and go through the steps of trying to solve them as a family. So a typical teenager, the issue may be, we can't get you up in the morning. There's always a battle in the morning to get you to school. What can we do? And we open it up for people to throw out different ideas, which might range from you have to go to bed earlier, you need to talk to your doctor about your Seroquel dosage because it's making you groggy, or you're not awake in the morning. You need to think about whether you should take your stimulant later or earlier, or whether the family needs to give the kid more time to get ready for school. All these things can be done in the context of active problem solving. That's the treatment in 12 sessions. Obviously, there are many complicating factors, divorce, for example, people living in different households, different family constellations, the mere chaos of trying to raise kids when you're also working, and so on. It's very hard to do all this stuff at once. And that's part of what we try to do, is help people manage the stress of this illness. We have 9 randomized trials at this point. And by randomized trials, I mean looking at medications plus this 12-session, or earlier it was a 21-session treatment with medications, combined with medications, versus various treatment as usual comparisons, which have been such things as briefer family education or case management, medication by itself. And the trials consistently show that the FFT leads to better outcomes of bipolar disorder, whether the patient is an adult or a kid, better trajectories of depression and mania, fewer recurrences, better compliance with medications. So we have reason to think this is a good thing to do in conjunction with medication if there's a family available and willing. Now, one thing that may occur to you is we aim for recovery, long-term recovery of this disorder. What does that actually mean? This is something the National Alliance on Mental Illness has debated for many years, as has the Progressive Bipolar Support Alliance. For bipolar disorder, we usually mean a sustained period of wellness and quality of life despite the disorder. So it's not having no symptoms of bipolar disorder. It's having a feeling of wellness and good quality of life where one is reaching one's academic or work goals, having good relationships at home, friendships, even though those times may be interrupted occasionally by episodes. And people who've really recovered well, it seems to me, have learned to balance those things. At a practical level, we look for 6 months without impairing mood symptoms, with good functioning in the work, family, and social domains. So this may not mean being free of symptoms, but it means being able to function despite symptoms and to be able to live the life one wants to live. That's really what we mean by recovery. Now, how do you promote recovery? These are the 10 principles we use for promoting recovery in adolescents and young adults. Some of these I think you can do by yourself at home. One is to monitor moods daily, to know about one's early warning signs. So there are a number of different online apps one can access to kind of record one's mood. Mood Recorder is one of them. Mood Recorder, I believe it's called. One of them is the Depressive and Bipolar Support Alliance, I think, has put together their own mood monitoring device. Any of those, the one you choose is not so important. It's keeping track of daily changes in moods, sleep, and some apps allow you to also record what's happening in your life, or even what medications you're taking at the time. There's nothing quite as important as just tracking mood over time. And if a person with a disorder is doing it, it often helps for a family member to do it alongside of them and say, these are the days I thought you were irritable, or these are the days when you seem more depressed. See whether the perceptions are the same across generations. Recognizing and managing stress triggers.
Would you be able to speak just a little bit closer to the mic, please?
Sure. Yeah, I'm sorry.
That's okay. Thank you.
Recognizing and managing stress triggers. So that really involves looking at what in the past has been a stressor for you, whether that's a change in seasons or going from summer to school, or certain life events, going to weddings, I think was one for a patient of mine. Knowing that certain stressors are likely to be followed by depressive or hypomanic episodes is often very helpful. And let me say a word about what kinds of stressors tend to be related to manic episodes. First, of course, are events that disrupt the sleep-wake cycle. So making transatlantic flights. This is a tough time for mothers and fathers who've just had a baby, since the sleep is so disrupted. Having constantly changing work patterns or work shifts, those can be very difficult on a brain that really emphasizes continuity and stability. The other kind of stress we worry about are sudden positive things that can happen that sort of get the manic juices flowing and get people thinking about what could happen in the future. So getting promoted on a job, some people get very carried away and start staying up late at night trying to be better at that job and thinking they'll get another promotion, or they get some money back on their tax returns and use it to develop a business that they've been wanting to develop, and that becomes a cause of heightened activity and rapid thinking. So we have to be a little concerned, not that we want them not to have positive events, but the time after a positive event can be a risk period. And it's important to know that going in. I mentioned regulating daily routines and sleep-wake rhythms. That's a good health habit in general for anyone, but bipolar people in particular do well with regular sleep-wake cycles. So it's not so much what time you go to bed, but do you go to bed around the same time and wake up around the same time every day, including the weekends? And are your routines somewhat regulated? We don't want this to turn life into a military academy, but we do want some regularity, because with regularity comes more mood stability. Now, know your position on medications. This is both for the person with the disorder and the family. I'm not saying you have to go and take whatever medications are prescribed. Nobody does that. You have to decide what you think you need in conjunction with your physician. You need to share with your physician what you believe about medications, your questions about why you're on certain medications, if you're a spouse or a parent, what side effects are we looking at, what developmental effects could these medications have. There's no question that the primary treatment for bipolar disorder is medications. You cannot treat it just with psychotherapy. But it's important to have a good amount of information on medications before you commit to a regimen. Otherwise, you have somebody constantly going on and off, and that can even be worse than not being on at all. So, why are we taking both a mood stabilizer and an antipsychotic? What's the antidepressant supposed to do? Why are we increasing the dose of the antipsychotic? Why are we adding another mood stabilizer? All those things should come out of an open discussion with your physician. I mentioned developing a mania and depression plan, knowing about early warning signs. You can do the same thing with depression by looking for signs of withdrawal, social withdrawal, loss of energy, sleeping more, which all can herald depression. The difference is that manic episodes can develop quite quickly, whereas depressive episodes tend to develop slowly. Open communication about marijuana use. I'm going to say a little bit more about that in the next slide or two, so I'm going to hold on that one for now. Working on family communication and problem solving, keeping in mind that during an episode, one's family skills or skills for communicating with people in the family tend to go by the wayside, and you really have to be kind of super efficient and helpful in communication in the aftermath of an episode, because that's when people are very vulnerable to stress, vulnerable to family conflicts, and sometimes can develop symptoms in high conflict environments. Sometimes you can get reasonable accommodations at work or at school. Bipolar disorder is a disability, as the Americans with Disability Act defines it. So that means you're entitled, if you've been hired on a job, to be in the best working environment possible. For people with bipolar disorder, that, for example, included working in well-lit rooms. If they're having problems with sleep, not starting too early in the morning. For kids who are having trouble getting up because of the side effects of their antipsychotic medications, maybe they shouldn't have math first thing in the morning. Have a lower key period at the beginning. These sorts of things can be negotiated with the school. The other thing to keep in mind, of course, is that if you want a reasonable accommodation at work, you have to also be willing to disclose the disorder. And some people stop there. They think that the disclosure will lead to them being fired. And unfortunately, that still does happen. It's happening less and less. And employers are now aware that a lawsuit could follow such a termination, but it's still happening. Arrange regular therapy and medication sessions. You shouldn't just see your psychiatrist once every 6 months. It should be semi-regular. Once every 3 months may be okay if you're stable and you don't have questions about your medications, but if your mood is unstable, you're going to need more sessions than that. And I usually recommend at least weekly therapy in the period after an episode. So for the first 3, 4, 5 months after a manic or depressive episode, when you're fully recovering, there should be a therapist, either individual, family, or group therapist that you can consult with. Finally, I like to say, to promote recovery in someone with bipolar disorder, parents and spouses take care of your own health. It's very easy for people to get wrapped up in the care of their loved one and forget that you're a human being too. That you need to do your own exercising and making sure that you're spending time with friends and have some downtime. That, of course, requires the cooperation of other members of the family. That's very important. Let's talk a little bit more about medication adherence. What should we do if we're a family or if we're a person with a disorder who's not comfortable taking medications regularly, or is planning to go off medications, or has already gone off and family members are quite worried about it? First thing to do is the side effects need to be discussed with the doctor, because often patients are unwilling to do that, and that's a real shame because sometimes side effects are treatable. They can be treatable by adjusting dosages or switching to another medication. Some side effects are only a real problem for the first couple of weeks after you start taking medication. So antidepressants, for example, people feel sort of tired and anxious and apprehensive on those when they first start taking them, but then 4 or 5 weeks on the road, they don't feel that way anymore. So if the issue is side effects, it is potentially solvable. For some people, the issue is forgetting, and if they have a lot of pills to take, there are various ways to remember with watch alarms or reminders or pill boxes, or sometimes setting up a schedule or a reminder via text message. The other thing you can do is talk to the doctor about whether there's a plan that could be followed. For example, the drug Abilify has a once-a-day dosing you can do. I think some of the other medications will follow suit. So that's an option. Now, it gets more complicated when medications have a meaning in the family, and this, of course, is something we talk about in our family treatment. Sometimes the medication is really hiding some other issues, such as the kid or the young adult feels she's taking meds for other people. My parents think I'm bipolar, and they're going to throw me out of the house if I don't take medications. I don't think there's anything wrong with me. I'll do it because they want me to, but as soon as I'm out on my own, I'm going to go off with them. And sometimes those same people go off well before they leave home. So there has to be some ownership. The person has to be convinced that this is going to improve their own life, that taking meds will help them get to their own goals. Sometimes they get pressure from family members to discontinue their medications. It's probably not one that we're all familiar with, but it happens a lot, for example, to kids in divorced households where the kid is spending Monday through Friday with mom and weekends with dad, and dad says, that medication you take, you have to take that when you're at my house, because that's really more for you. That's your mom's thing. That's not my thing. And sometimes one parent is not really behind the medications. And certainly when a kid could decide to unilaterally go off medications, one of the first things I ask is for both parents on board medications with the treatment plan. So they may be in conflict about the treatment, and the kid is aware of that and is using that to justify non-adherence. In older folks, by older I mean people over the age of 21, taking medications can have some symbolic significance. I don't like taking medications because they lead to a loss of creativity. I have to give up my emotions. They flatten me out. They make me feel blunted. I used to be a good painter. Now my paintings are boring. Or I used to write music, and I can't write music anymore. And these are some real issues because medications can make people feel beaten down and don't allow the same emotional volatility that they had before. And that's a question really that has to be taken up position, whether, for example, the person can get away with a lower dose and allowing them some more emotional variability without risking mania. Sometimes the issue is more of a psychotherapy issue, like what we call grieving over the lost healthy self. When people get into their early 20s or so, they start thinking about, my life was pretty good up until about age 18, and then I had my episode, and now my life is all about doctors and keeping sleep cycle and all that stuff. living at my parents' house, I used to be a better, more exciting person, and then I got ill, and now everything's going downhill. That person can be at risk for going off medications because they feel like it's a way to kind of regain their former self. And that's not something you can necessarily deal with as a family member, but that is an issue that psychotherapists should be addressing. And by the way, let me mention that I think it's ideal, and I realize these are hard to find, but it's ideal to find a therapist who knows something about bipolar disorder. Many people say they do, they don't necessarily do, but you don't want to be treated with some generic counseling technique. You want somebody who knows how to recognize mania and depression, and the rules are functioning with that illness. Good sleep hygiene, I think we know what that is. Most of us having a regular bedtime and wake time, allowing it not to vary more than an hour a day. So you sleep an hour later on the weekend rather than 4 hours later. Avoid sleep binging on weekends. Some people, I've done that myself. You kind of avoid, you try to catch up on the sleep you didn't get by sleeping all day on the weekend or sleeping very late on Sunday. That can have effects on the sleep cycle for the week. For kids, often the issues with the cell phone, the iPad, and they're up late at night texting their friends who are also up all night texting their friends, and at some point those screens have to be turned off. Avoiding caffeine. There are people who think you're supposed to take your stimulant medication before you go to bed, and obviously that's not a good thing to do. Stimulants should be stopped around 2 in the afternoon for it not to have an effect on sleep. Stimulants like Adderall or caffeine. Obviously avoiding alcohol, drugs, or activating medications. Exercise is an interesting one because many people try to exercise right before they go to bed, not thinking that it'll somehow help them sleep, but actually the evidence is the opposite, that if you exercise too late in the day or early in the evening, it can kind of wire you and have trouble falling asleep at that point. So after work or after school is probably the best time. Avoid homework in the bedroom. Avoid catching up on emails in bed right before bedtime because those tend to crank people's thoughts up. And for those of you who are having ongoing sleep problems, I'm going to suggest an online sleep regulation program. It's a British group, the Sleepio company. It's a little bit low tech. It's got a professor who kind of lectures to you about sleep and has you fill out various exercises involving tracking your sleep and trying sleep restriction and various other techniques. And I do think it's useful. It's about a 6-week-long program. People do report improvement in their sleep. Okay, let's get on to the whole issue of marijuana. So here you have a picture supposed to represent that painting on the Sistine Chapel. One person handing a joint to another. Why should we discourage marijuana use in young people with bipolar disorder? And by young people, I mean here both teenagers and young adults. I mean, here in California, medical marijuana is now legal. So people are asking, why shouldn't I smoke it or eat it or whatever people are doing? Now, the evidence shows that medical marijuana is neither a mood stabilizer or an antidepressant, even though people say this helps me more than my lithium or more than my Depakote or my antipsychotic. There is not evidence that it's a long-term mood stabilizer. In fact, regular cannabis use has been found to be associated with suicidality and risky sexual behavior in adolescents. Now, it may just be that people who are using cannabis regularly are also at risk for those behaviors because it puts some element. But we do know that regular cannabis use is risky. I would avoid getting into the idea that it's self-medicating, that people are using marijuana to medicate a negative illness state or a negative emotional state. That's sometimes true in bipolar disorder, but it's sometimes not. Some people also smoke a lot of weed when they're feeling okay, and people feel better when they're high for a short time, but it doesn't necessarily. It isn't necessarily when the illness is at its worst. And overall, the course of bipolar disorder can be worsened by using a lot of weed. There is some evidence that it reduces learning, attention, and memory recall. There's some neural findings that have emerged from MRI studies about gray matter volume in these new book. The Fear Center and the hippocampus is involved in learning and memory. Emotional salience is part of what the amygdala does. So we don't know what those mean yet, whether those are significant, but it's a difference between regular cannabis users and non. Also, there's so many different kinds of marijuana out there, and dosages and strengths that are unpredictable. We don't know whether what people are buying is just marijuana or has other drugs in it. It can interfere with sleep and adherence. And of course, we know that anxiety and paranoia sometimes get worse when people use it. Now, I'm not trying to paint a reefer madness type of negativity and apply it to marijuana. I realize there are people who say that it helps them quite a bit. But for the specific issue of kids and young people with bipolar disorder, they're not doing themselves any favor by smoking a lot of weed. It doesn't prove their illness and may actually make it worse. A little bit about diagnostic differences. How are borderline personality and bipolar disorder similar or different? As you may know about borderline personality is a personality disorder characterized by a lifelong maladaptive pattern of functioning. We usually look for borderline personality in adults. It's less likely to be diagnosed in kids. There's certain distinct characteristics like being afraid of abandonment or difficulty being alone, very unstable relationships, and emotional swings and outbursts of anger are very common in borderline personality. It's hard to sometimes distinguish from mania or depression. And of course, people with borderline personality are very at risk for depression, although they're not at risk for mania. And I think that's an important point. They're at risk for depression, but not necessarily at risk for mania. So when we think about how are they different, both have mood instability. Both have these changes, say from anxiety to depression to feeling okay to being angry, being hyper for a few minutes. But the shifting moods are kind of a steady state in borderline personality. They're always kind of there. They're not so like in bipolar disorder where you have not only mood changes, but also changes in sleep and changes in activity level, grandiosity, energy, fatigue, all those things occur in groups of symptoms, whereas in borderline we're talking more about just a shifting pattern of mood, which it tends to be ongoing as opposed to an episode. Actually, although people with borderline are always kind of moody and have that as a personality attribute, changes in mood are often very short. So you have some sort of a trigger. Boyfriend breaks up with you, or boyfriend isn't supportive somehow, and then the person really feels enraged and may have a really difficult day and can be gone by the next day. But over time, this becomes kind of a chronic pattern. Again, mania doesn't seem to occur in borderline personality like it does in bipolar, but sometimes we go ahead and we diagnose both at the same time. There isn't a particular treatment for the combination, but we know that it's usually more intensive therapy than it is if one just has bipolar disorder. ADHD, there's been a lot written about how are bipolar and ADHD alike and different. Most people say, well, if you kids with rage and hyperactivity, they can be either one. But then again, we don't diagnose bipolar in kids on the basis of rage anymore. That was done for a long time. Rage attacks can occur in a lot of different kinds of childhood conditions, not specific to bipolar disorder. Here are some of the symptoms that do occur in bipolar disorder that don't occur in ADHD, like elated mood, grandiosity, decreased need for sleep. Now, that's different than just insomnia. We do see insomnia in ADHD, but it's not the sleeping less and still being energetic the next day. Flight of ideas, we tend to see that in bipolar, even though kids with ADHD may be chattering away, they're not necessarily changing ideas in the process. Hypersexuality also and psychosis characterize bipolar more than ADHD. But there are also some symptoms that overlap. Irritability, I just mentioned, occurs in both. Just the rapidity of speech is common in both. Distractibility occurs in both, and increased energy can occur in both. So we really look again for more like elated mood, grandiosity, decreased need for sleep, hypersexuality, psychosis as the distinguishing features. And sometimes we have to look over time to really understand this. I'm going to end with just talking a little bit about bipolar disorder and creativity. I think you've probably heard of various news items about that there is, and of course Kay Jamison's books on Touch with Fire and so forth that have talked about the connection between bipolar disorder and the artistic temperament and the high rate of creativity that is often found in bipolar people. And there is some truth to this. This is the whole topic of what we call psychohistory, where you go back and try to apply modern diagnostic methods to people who've been writers or musicians, and it's a little bit of a questionable research method, but those who have done this kind of work have found that there's quite a bit of mania in some of our best writers, including Ernest Hemingway, F. Scott Fitzgerald, Joseph Conrad, Virginia Woolf. These are all people who've had, and by the way, Robert Lowell, who was the topic of one of Kay Jamison's most recent books, have all had manic episodes, sometimes with suicide attempts and hospitalizations. In addition, we know that a number of musicians and composers have had manic episodes, varying anywhere from classical, Mahler, Mussorgsky, Berlioz, Handel, and to modern rock music, including Kurt Cobain and folks like that. So it's a very common illness among the very talented. What does the research actually say about bipolar disorder and creativity? Is it just sort of these anecdotal findings, or is there evidence that people with bipolar disorder are more creative? Now, there is some evidence that creativity is higher among people with bipolar disorder than among non-psychiatric controls. It's the way the literature refers to normal people, that the creativity, and they test creativity in some unusual ways. For example, think of as many uses as you can for a brick. And very creative people will say things like grind it down and add some water and turn it into paint, or even better ones than that. So, but those kinds of tests tend to show bipolar people coming out ahead. People in creative professions, like writer and musician, are more likely to have had bipolar disorder than people in the healthy community. We also see it in the first-degree relatives, that even though a person with bipolar disorder might have relatives who don't have bipolar disorder, there is a heightened rate of creativity in the family tree. So we wonder if that's related to this sort of artistic temperament that may be inherited in some people outside of bipolar. On the whole, creativity seems more linked to hypomania than mania. When people are hypomanic, they get the sort of increased activity and energy and elated mood, but they're not dysfunctional in the sense that they're not going to end up in the hospital. They're more wired, able to produce a lot with less sleep. Whereas in mania, you're really talking about someone who ought to be hospitalized, maybe delusional, maybe picked up by the police, maybe driving very dangerously. When people are manic, they tend to produce a lot, but it's not really their best work. So they do dozens of paintings and dozens of poems, but some of them are just scribbles on page, whereas the more hypomanic variety, sometimes it opens the door for more creative thinking. That raises, well, do we treat hypomania? What if the person has bipolar 2 and only has depressions and hypomanic episodes? Should we necessarily treat hypomania if it's associated with something good like creativity? Most psychiatrists will say they have somebody with bipolar 2 with hypomania. The concern, of course, is that hypomania tends to bring along a depression in its wake. So once the person comes out of hypomania, if you allow them too many hypomanic episodes, they have more and more depressions. So we emphasize careful monitoring of moods and activity, make sure that there's adequate sleep. Sometimes doctors will recommend transient use of a sleep medication if the person is unable to sleep. Sometimes they do adjust mood stabilizers or antipsychotics. Really depends upon what has happened in the past with hypomania. Has it escalated into mania, or is it always followed by a depressive episode? Not every hypomanic episode needs to be treated with medications. If there's an antidepressant, sometimes we discontinue it. There are plenty of examples, since we know that antidepressants can be associated with hypomanic or manic rebounds or switches into mania or hypomania if you're taking an antidepressant. Sometimes taking an antidepressant away can stabilize a hypomanic episode. Our rule with antidepressants is they should always be prescribed alongside a mood stabilizer or an atypical antipsychotic. A couple of new treatments that are coming down the pike. Some of these are already in wide use: lorazepam, ketamine, aripiprazole, lamotrigine. I'll be happy to talk about some of those in Q&A in just a second. We have a couple of psychosocial treatments. I mentioned FFT. Dialectical behavior therapy is treatment, a modification of cognitive therapy that mindfulness, distress tolerance, and meditation, and learning how to tolerate negative mood states and not having to act on them. Mindfulness-based cognitive therapy, our group meditation sessions, sometimes over as many as 8 weeks, with a cognitive therapy element to them, but mainly oriented around learning to meditate well. And we're going to start seeing more internet-based programs. I'm a little bit ambivalent about those as solo treatments. People are saying, well, you don't have to see a therapist now, you should just do an internet program. If the goal is just to learn about the disorder, yeah, I think you can go to an internet site or buy a book or buy a workbook. But it's not the same as having a therapist who understands your story and can help you figure out what's happened before and not make the same mistake again. So, I think I will skip most of this, but we are developing an app that can be used alongside of family-focused therapy. Here's an example of the kind of data we have. Children rating their moods on a daily basis from -3 to +3, or their stress levels at different days, and we can kind of go over that with them and try to figure out what's causing stress or what's causing these mood swings. But they can do it right there on their phones with a reminder from us rather than having them fill out a piece of paper or having to do very time-intensive interviews. But I think we're going to see a lot of programs that involve apps in the near future. So our take-home messages here: bipolar disorder is highly recurrent and disabling often. The stressful effects of the disorder can fall to parents and spouses unfairly at times, but it's often parents and spouses who are picking up the pieces. Bipolar disorder can be treated to recovery with optimal combinations of medications and either family, individual, or group therapy. I didn't get to talk much about individual or group, but there are some interesting methods, good methods involving CBT and dialectical behavioral therapy. But we need both therapy and medications for the outcome to be optimal. There are illness management strategies I've talked about, like sleep regularity, mood monitoring, all of which can contribute to a good recovery. And the good news is that once people are stabilized, people with bipolar disorder often make highly creative contributions to society. And we have to keep that in mind and remember that no one's written a story until it actually occurs. So, and caregivers, please remember to take care of yourself. Do go to that yoga class. Do go to the gym. Take some time with friends. Read my book, please. So, a little ad for that. And the only other thing I wanted to do is read this quote from Kate Hamilton. To close off, I cannot imagine leading a normal life without both taking lithium and having had the benefits of psychotherapy. Ineffably, psychotherapy heals, makes some sense of the confusion, reins in the terrifying thoughts and feelings, returns some control and hope and possibility of learning from it all. It is where I have believed, or have learned to believe, that I might someday be able to do this. That's her book, An Unquiet Mind, talking about the benefits of both psychotherapy and medications. So, Aubrey, I'm going to stop here, and I guess we'll take questions from here.
Okay, we have about 5 minutes left on this, so we can take 1 or 2 questions, and then if you have any questions about where you can get the book or any of that, you can email me at agood@ibpf.org, and I'll forward you all of that information. I do have that available. So like I said, if you want the book, please email me and I can direct you as to where to get that. And we have a free chapter available on our homepage at www.ibpf.org. Did we have any questions? I do not see any quite yet. You guys have a couple minutes, so if anybody has a question and wants to throw that out. Where can I get the book from?
Amazon. You can get it from Amazon or the Guilford Publication website.
Okay. Any other questions, guys?
I'm surprised. I'm usually deluged with them.
Oh, just any thoughts on ketamine?
Okay. Yeah, ketamine is an interesting option. It's now available in intranasal form. For a while, it had to be given with a stomach tube, and now it's been licensed as a spray, a nasal spray. What we know about ketamine is that it pulls people out of a depression very quickly, much faster than many of the medications we use. The problem is it can be addicting. It is a street drug, and there's some evidence it can go along with hallucinations in some people. And also, the effects don't seem to be very long-lived. You have to be taking it regularly. It's not like one dose. You have to be using the spray reasonably often to get its full benefit. So I think it's promising, but it's not the cure-all we'd hope for.
The next question is, how do I carry on in a stressful job that I'm mostly high-functioning in?
Well, I think that raises the whole question of whether you want people in the work environment to know about your disorder. If they do know about it, it's a lot easier to ask for accommodations and various accommodations might be a more flexible work schedule, flex time as they call it, working at home maybe part of the time, not starting too early in the morning, having more reviews of your work so that you don't know whether you don't fall into wondering what people are thinking of you. All those things can be asked for, but again, they require disclosing your illness. If you don't want to disclose your illness, then I think it's really, you're kind of limited to talking to your boss about, can you get some of those accommodations without having to explain why? And that's a little harder to argue for.
Do you have any thoughts on CBD oil?
Yeah, CBD oil, I know is, some people are using it for pain. That's actually the main use of medical marijuana right now, is for pain and for post-cancer surgery. I've heard of some people saying that it makes them feel better, but I would say the same concerns I raised about marijuana in general are also true of CBD oil. I'd like to know a lot more about its mechanisms in bipolar disorder. I'd like to see some outcome literature before people take that up as a method of dealing with mood states.
Okay, it looks like we are out of time. So as I said, if anybody has questions, you can email me at agood@ivpf.org. You can access a free chapter of the Bipolar Disorder Survival Guide on our homepage, www.ivpf.org, and then you can purchase the book on Amazon or Guilford. And we did send you a 20% off coupon with your registration. If you did not get that for any reason, please contact me and I'll send that to you. And we thank you so much for joining us today, and we hope everybody has a wonderful weekend.
Thank you.